Last of the last, critical to know before the test. Neonatology. Newborn born at home is bleeding plus prolonged prothrombin time is hemorrhagic disease of newborn. The next step is to give IV vitamin K. Newborn with oxygen saturation in the right hand is between 90 and 94%. The next step is to repeat in 1 hour. Newborn with diffuse edematous swelling of soft tissue of the scalp crossing the suture lines is caput succedaneum. Newborn with localized firm and tense mass never crossed the suture lines is cephalhematoma. Isolated pits and tags reassure the family. No need for renal ultrasound, but if you have malformed ear, renal ultrasound is recommended. Newborn respiratory distress, absent breath sounds on the left side, scaphoid abdomen, chest x-ray shows intestinal structure in the left side of the chest. This is congenital diaphragmatic hernia. Pneumatosis intestinalis, as you see here, air in the intestinal wall, is pathognomonic to necrotizing enterocolitis. Gas in portal vein is a poor prognostic factor. Formula feeding is a risk factor and a well-known cause in premature infants. Renal vein thrombosis in neonates presents with sudden onset of hematuria, flank mass in one or both sides. Risk factors: sepsis, shock, dehydration, maternal diabetes mellitus, or hyperthrombosis or hypercoagulable states. Metabolic disorders: normal to high ammonia level with high NAGAB acidosis or metabolic acidosis is organic acidemia. Be familiar with the diseases of organic acidemia, propionic acidemia, methylmalonic acidemia, isovaleric acidemia. Very high ammonia level without metabolic acidosis plus or minus respiratory alkalosis is urea cycle disorder. Be familiar with OTC, citrullinemia, argininosuccinic aciduria. Progressive developmental delay, coarse facial features, macroglossia, macrocephaly, hepatosplenomegaly is mucopolysaccharidosis. If it's normal cornea, is Hunter. If it's cloudy cornea, is Hurler. Severe splenomegaly, lytic bone lesions, and decreased glucocerebrosidase is Gaucher disease type 1. Adolescent medicine. Currently, iron supplementation is recommended for adolescents between 14 and 18 years of age. For boys, the recommended dose 11 milligrams of iron per day for rapid growth. For girls, 15 milligrams per day for rapid growth and menstrual blood loss. Iron supplementation with these doses is recommended even with normal hemoglobin level. Trichomoniasis is a common sexually transmitted infection caused by Trichomonas vaginalis. Bacterial vaginosis is not sexually transmitted infection. The presentation: valvar itchiness, valvar soreness, and irritation. So irritation is common with trichomoniasis, not with bacterial vaginosis. The discharge is malodorous, yellow-green, here is white, and thin, frothy discharge. The pH is high, is more than 4.5, and under microscope you will see flagellated pyriform protozoa, and the treatment is the same, metronidazole. Physiologic leukorrhea or normal vaginal discharge. It is clear or white, odorless discharge. When it's dry, it will look yellow stain in the underwear. It is influenced or stimulated by estrogen. It starts 1 to 2 years before puberty and fluctuates during different phases of menstrual cycle. It is asymptomatic, no irritations. Different than cases of bacterial vaginosis. Components: normal flora, lactobacillus, epithelial cells intact, not ragged like in cases of bacterial vaginosis, and a few white blood cells. The treatment: reassurance. An adolescent with cough, chills, shortness of breath, and increased heart rate, antibiotics are not improving the symptoms, and using e-cigarettes. The diagnosis is e-cigarette or vaping-associated lung injury or E-valley. Next step is to discontinue e-cigarette or vaping. Most cases of E-valley respond to systemic steroids, not antibiotics. Gastroenterology. Projectile vomiting in 4 to 8 weeks old with dehydration, hypochloremic, hypokalemic metabolic alkalosis is pyloric stenosis. Best initial study is pyloric ultrasound, and the best initial treatment is IV hydration, then surgery. Localized abdominal tenderness is the single most reliable finding in the diagnosis of acute appendicitis. Abdominal ultrasound is the best initial study. Abdominal CT scan if the appendix was not seen on ultrasound. Intussusception is the most frequent cause of intestinal obstruction in children. Lethargy and a change in mental status may be the only initial presentation. Abdominal ultrasound is the best initial study, and the treatment of choice is air contrast enema. Tremors, depression, posterior cornea looks golden yellow, and liver is enlarged is Wilson disease. In Wilson disease, the ceruloplasmin level is low, less than 20 milligrams per deciliter, and this is the best initial screening test. And high urinary copper more than 100, and liver biopsy will confirm the diagnosis. Kaiser-Fleischer rings are gold, greenish, or brownish rings encircle the cornea due to copper deposits. Copper is elevated in Wilson disease. Kaiser-Fleischer rings are pathognomonic for Wilson disease and best seen by ophthalmologists with a slit lamp. Pediatric neurology. Staring and behavior arrest. EEG showing 3 Hz generalized spike wave discharges is absent seizure or petit mal epilepsy, and the treatment is ethosuxamide. Adolescent who is clumsy in the morning with myoclonic seizures or jerks, the EEG is 4 to 6 Hz spike and polyspike waves is myoclonic seizure. The treatment is for life with valproic acid or levetiracetam or Keppra. Initial treatment of choice for migraine headaches is NSAID or acetaminophen. Prophylactic to prevent recurrent migraine headaches, cyproheptadine, topiramate or Topamax, propranolol or valproic acid in severe cases. Best initial treatment of cluster headaches is 100% oxygen. Also, triptans may abort the headache. To prevent cluster headaches, verapamil is the drug of choice. Staring and behavior arrest, EEG showing 3 Hz generalized spike wave discharges is absent seizure or petit mal epilepsy, and the treatment is ethosuxamide. Adolescent who is clumsy in the morning with myoclonic seizures or jerks, the EEG is 4 to 6 Hz spike and polyspike waves is myoclonic seizure. The treatment is for life with valproic acid or levetiracetam or Keppra. Epidural hemorrhage appears on CT scan as convex lens-shaped hyperdensity. Subdural hemorrhage appears on CT scan as crescent-shaped hyperdensity. Renal system. Hematuria 2 weeks after upper respiratory tract infection. Blood pressure is slightly elevated. Red blood cell cast in urine. Low C3 and normal C4 is post-infectious glomerulonephritis. Hematuria, usually gross hematuria, lots of blood and recurrent, with upper respiratory tract infection during, with normal C3 and normal C4 is IgA nephropathy. History of impetigo treated with antibiotics a few weeks ago, associated with decreased output or oliguria, hematuria, hypertension, red blood cell cast in urine, low C3, normal C4, and elevated deoxyribonuclease or DNase antibodies. This is a case of post-streptococcal glomerulonephritis. Genetic disorders. Intellectual disability, hypotonia, upslanting palpebral fissures, speckled iris or brush field spots, endocardial cushion defect, Down syndrome. An adolescent who is tall with learning disability, gynecomastia, small firm testes, high LH and FSH and low serum testosterone. Klinefelter syndrome. Pulmonology. Upper respiratory symptom, barking or brassy cough in respiratory stridor is acute viral laryngitis or croup. Giving 0.6 milligrams per kilo dexamethasone will shorten the illness and minimize severity. Cardiology. This is a 14-year-old with chest pain. The pain is worse during inspiration and while laying flat. What is the AKG finding? Prolonged QT interval, ST segment elevation, prolonged PR interval, right ventricular hypertrophy. I will give you a few seconds to look at it. The correct answer is ST segment elevation. You have ST segment elevation in all leads. This is consistent with pericarditis. This is an ECG for 14 years old with a chest pain. If you look at the ST segment here, if you compare it to the TP segment from the end of the T to the beginning of the P, it is elevated in all leads as you see here. Elevation of ST segment in all leads, this is perimyocarditis. This is a case of acute renal failure with hyperkalemia with serum potassium 6.5 mg per deciliter. Very important to know that the changes in the T wave and the ECG with hyperkalemia depending on the level of the potassium. Like in this case, 6.5, as you see here in the precordial leads, the T wave is peaked and tall. But if the serum potassium goes higher than that, for example, this can cause prolonged PR interval, decreased or disappearing P wave and wide QRS complex. Very important to keep in mind. Subacute bacterial endocarditis antibiotic prophylaxis for dental procedures, respiratory procedures, skin infection procedures no longer recommended except in a few cases. Exceptions are easy to remember. I will mention here the common or high yield one: unrepaired cyanotic heart defects, complete repaired heart defects with prosthetic material or device for 6 months, prosthetic cardiac valve, previous history of endocarditis. Hypertrophic cardiomyopathy is one of the most important causes of cardiac death. If the patient survives, the symptoms are recurrent syncope, palpable thrill at the left mid-sternal border, or palpable thrill on the chest, equal pulses in all extremities, so is not coarctation, harsh crescendo, decrescendo, or systolic murmur, best heard between the apex and the left lower sternal border. Very important to know that standing will increase the intensity of murmur, while squatting or sitting will decrease the intensity of murmur, and hand gripping as well will decrease the intensity of murmur. One hint to remember: standing is taller, will increase the intensity of murmur, and squatting will be shorter, and hand gripping will be smaller. Both will decrease the intensity of murmur. Best treatment is beta blockers and restriction of competitive sports. Infectious diseases. Herp angina or enteroviral vascular pharyngitis is caused by enterovirus or Coxsackie virus. The characteristics: you will see discrete vesicles clusters more on the tonsillar pillars or the anterior tonsillar pillars, and you'll see that more in younger children. This picture for an older child. And you will see it also in the soft palate uvula, associated with high fever, drooling, and poor feeding, especially in young children. The treatment is supportive. Hand, foot, mouth disease. The other name is enteroviral vesicular stomatitis with exanthem on hands and feet. Also, this can involve the trunk as well. Associated with mouth ulcers, as you see here on the buccal mucosa, and you will see sometimes on the tongue. Associated with petechial rash in hands and feet, arms, legs, and the trunk as well. The most common cause of breast abscess in a newborn is Staphylococcus aureus. The best treatment is anti-staphylococcus against MRSA or MRSA, such as clindamycin or vancomycin. Avoid giving Bactrim to newborn. Development of tissue cellulitis or even osteomyelitis after stepping on nail through sneakers caused by Pseudomonas aeruginosa. The antibiotic of choice is oral ciprofloxacin. Hematology. Autoimmune hemolytic anemia. Be familiar with all the keywords. This is common during adolescence. So if you have an adolescent who's previously healthy with recent history of upper respiratory tract infection, start to be tired, having fatigue and pallor, anemia, jaundice, splenomegaly, high retic count because of hemolysis, high bilirubin, and high LDH. The best next step To confirm the diagnosis of autoimmune hemolytic anemia is to order direct Combs test. The other name is direct antiglobulin test. In this case will be positive. The best treatment option in this case is corticosteroids. Mixing study. Understand when to order it and understand the result. You can order it if you have a patient with prolonged PTT or PTE. You can mix the patient plasma with normal fresh frozen plasma 1:1. If it doesn't correct the PTT or PT or both, there is an inhibitory factor, for example lupus anticoagulant or antiphospholipid syndrome. If it does correct, there is a factor deficiency. If you have prolonged PT, this means there is a problem in the intrinsic pathway. Most commonly, you will have factor 7 deficiency. If you have prolonged PTT is correcting, there is a problem in the extrinsic pathway. So it will be a deficiency in either factor 8, 9, or factor 11 or 12. Peripheral smears. Howell Jolly body. These are small, round, dark staining inclusions seen in the red blood cells. These are remnant of the nucleus, supposed to be removed by the spleen. Why is seen here? Because this is a case of sickle cell anemia with autosplenectomy, so you will see the Howell Jolly body. Also, this can be seen in any case after splenectomy. Pediatric endocrinology. Low free T4, high TSH, and positive thyroid peroxidase antibodies is Hashimoto thyroiditis. We know the common associations: type 1 diabetes mellitus, Turner syndrome, Down syndrome, and celiac disease. All thyroid nodules. The best next step is ultrasound guided biopsy with fine needle aspiration. Very important to be familiar with suspicious nodules. Palpable thyroid nodule, more than or equal 1 cm in imaging, or if calcifications, or the border is irregular, or increase the blood flow on Doppler ultrasound. Dermatology. Keratosis pilaris. Pityriasis alba. Reassure the parents this is not anemia. Hydration of the skin will help. You may use or may recommend using low potency topical hydrocortisone. This is a contact dermatitis because of the nickel in the belt. And if the child avoid wearing this type of belt, this will disappear with time.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.